in here, and so it'll go across the internet for posterity. Supposed to do a roll call. Why are you looking at me funny, Beeson? Okay. We actually have a quorum. We have 11 members. We have 6 present, 1 on the way, stuck somewhere around Lorena, Texas. He's been sending me emails that he's on his way, and that's Dr. Phillips. We have alibis from some of the other gentlemen, and then I will go ahead and start the meeting by calling everyone's attention to the vision and the mission of GTAC, which we agreed at our retreat about 1.5 years ago. We would make sure everyone understands why we're here. The vision is for a unified, comprehensive, and effective EMS trauma system for a healthy, safe Texas. The mission of GTAC is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. Moving forward, I have not seen Dr. Nemeth. Is he present to talk about the TCEP EMS seminar? Anyone else besides me been involved in it? Everyone up here is involved in it. It's going to happen. It's going to be on Monday and Tuesday. It's the first time in many, many years that we have done the TCEP EMS Medical Director Seminar in conjunction with the Texas EMS meeting, and we hope that it increases the attendance of both medical directors and interaction between medical directors and their services. Number 2, second agenda item, review and propose placing a link to the International Association of Fire Chiefs Handbook for EMS Medical Directors onto the GTAC Medical Directors webpage. This would be an action item for the committee. I will open it for discussion or a motion or something.
Motion to place on the website.
I second the motion to place.
Any discussion? Anybody opposed? It shall be done. Excellent. We can finish in an hour, I bet. Okay. I'm going to jump around on the agenda for those of you that have the agenda to try to get some of the discussion done early and reports towards the last, if that's okay with everyone. I'm going to jump down actually to number 7. Actually, I'm going to jump to number 8 and ask Dr. Jarvis to discuss something that he put together and then was reviewed and edited a little bit. GTAC position statement regarding EMS medical directors' responsibilities for students on clinical rotations. You should have a copy or you can access it on the internet.
So the issue for this statement essentially was who is responsible for the paramedic student or the EMT student in the clinical environment. There was some question about overlapping responsibilities between the medical director of the education program and the medical director of the clinical site. And this statement just clarifies that the medical director for the system has the authority and responsibility for the clinical practice in that system. So the medical director for the education program is not the one on the hook, if you will, for the clinical practice in the field. The medical director for the education program is on the hook for the educational competencies, what's taught, and making sure that the students achieve those competencies. That's a different responsibility than making sure the clinical care that's provided is good. The other issue was the medical director of the EMS system may or may not actually be involved in the agreements between the training facilities and the EMS system. That's obviously, we think, a bad thing, since the medical director for the system is going to be ultimately responsible for the care provided by everybody in the system. We feel like the medical director for the system should be involved in approving those affiliation agreements. So our position statement just clarifies this, and it says, or the draft statement, it says the clinical medical director is responsible for the clinical care, the education director is responsible for the education, and the system medical director needs to have sign-off on the affiliation agreements. And we are in this asking, in this draft, asking DSHS to add in a requirement for program approval that basically says that.
You don't have a copy? I've asked that I'm going to see if we can actually project the document. If you have internet access, by the way, you can get internet access through the Hilton for only $90. That's what came up on my Wi-Fi, yes. You should have the document on your computer, sir. So, since everyone does not have a copy, there are actually 3 bullet points that I would like to discuss. There's good discussion and context, and then there's 3 bullet points. The first bullet point, and I'll just read what will be forwarded to GTAC. This is on GTAC's agenda. I tried to do both of the position statements we're working on today to be on the GTAC agenda so we could take action at both committees, or at the committee and the council. First of all, position. It is the position of GTAC that, number 1, while functioning within an EMS system, all practicing providers and students fall under the authority of the EMS system medical director. I would like to open that for discussion. I'd like to take these bullet points one at a time. Dr.
The
Beeson.
wording system, should it not coincide with what we currently call a provider? Or, remember we went around this earlier with the other?
There are students that are on first responder vehicles as well, so they are not a provider.
Okay.
I don't know that we thought that out, but we have students rotate on with first responders. They would not be covered under provider.
I'll remember that. I think the EMS system is more.
What? I can't hear you.
Do you need this?
That's a first. I think that EMS system is a broader term.
Any other discussion? Are you okay with that, Dr. Beeson?
Yeah, I just want to make sure that we don't contradict or all the wording for where it is here and what it's called there, just so if it's viewed as a system, then I'm fine with a system.
Okay.
Should be coming to your email.
All right. Any discussion from the audience on this item? I'll take a motion to approve. I'm going to do these one at a time. Never mind. Here we go. Yes, sir. Please identify yourself speaking in the microphone so everybody can hear.
Good morning. My name is James Shiplett. I'm the EMS Education Program Coordinator at Collin College in McKinney, Texas. Question to Dr. Jarvis.
I can't hear. I can't hear. No, just, you have to almost eat the microphone.
How's this?
That's good.
Okay, my name is James Shiplett. I'm the EMS Education Program Coordinator at Collin College in McKinney, Texas. Question to Dr. Jarvis. This has not been an issue before. Is there an incident or something that has caused this to come to light recently?
So basically, the reason that I wrote this is I was conveniently dispatched for Cheetos. When I came back, I had an assignment. I think it has something to do with him telling me to do it. It's not been an issue for me. The reason that my understanding of the problems really deal not so much with the conflict between the 2 medical directors. So I don't think there's been a huge war there. I think there's been some question about who's actually responsible. But I think the big issue is you have some EMS training programs making affiliation agreements with EMS systems, and that system medical director knows nothing about it. And they're the ones with the ultimate responsibility. And I honestly agree with them that that's something they should have knowledge of. So there are 2 things: the confusion, which I don't think was a huge, overwhelming issue, and the medical director not knowing who their system has affiliation agreements with.
Well, with that said, we're very fortunate in our program to have 2 medical directors. In fact, Dr. Malone is our associate medical director. But ultimately, as far as the DISH's rule is now, and the Commission on Accreditation for EMSP programs, is that the liability for that student falls under the medical director for the educational program. Now, should there be some sort of a memorandum of understanding between the 2 medical directors? Absolutely. But I don't know of a service medical director that's going to sign off on a student that he or she knows absolutely nothing about. And so I think it's a trust issue between the medical directors. If the best way to handle it is through that agreement that you have to sign, the clinical agreement, that's fine. But I'm just not seeing it as a big issue right now.
Actually,
you.
from COA doesn't specifically cover the clinical setting responsibilities. The issue arises when the educational standards or the protocols or whatever you're teaching or you're educating in your system is different than the clinical rotation site. There is clinical responsibility of the medical director over that entity that's licensed by the Department of State Health Services to transport and care for these patients. This is an issue that needs to be clarified because depending on who you ask, the interpretation of that is different. There is no question there is responsibility of the medical director of the educational program. I'm that also. But there does come in issues where there are conflicts between medical directors. Jeff's nicer than some. And when you have entities that now in our realm, maybe not in your area, that some transport providers are using this as a revenue, where now they're charging preceptors or they're charging for students to come do rotation preceptors. There's even more liability at this point. So this is really an issue that needs to be clarified, I feel. It truly needs to be clarified. And the second bullet points are even more.
And just to be very clear, we, in this time, I have two hats also. Wearing my EMS system medical director hat, we are absolutely responsible for those students' clinical practice, without a
I
doubt.
would agree with that.
Right.
There's no way that education medical director can know anything about what's going on in my ambulance. I have to be responsible. I mean, there's just no way that I can relinquish that control once they enter my ambulance. I have to be their medical director, and my responsibility is to make sure that that student doesn't exceed what they're trained to do. Therefore, I would actually add a fourth item here that says the student riding on any of my trucks has to show proof of the level of his training. He may be a paramedic student that has never started an IV, for example. He has to show me that his preceptor has checked him off for IVs before he gets on my truck. That is oftentimes not done. People just show up for a rotation and the paramedic doesn't know what the student has been trained to that level. And they're always changing. Every time they go to class, it's a different thing. So you need to upgrade that at the end of every session.
I think that falls under item number 1. If they fall under your authority, then your authority can dictate what they have to do.
And those are also those things about how does the preceptor know what the objectives are and those progressive objectives. I think that is actually fairly well covered in other parts of the accreditation standards. I think the question really is whose authority is it? And the bottom line is I'm liable for it. There is no way you're going to find an attorney anywhere who's going to say it's not my responsibility. I'm the responsible physician. I'm the authorizing physician for everything that's done on that system. So it's my butt, and I need to have the authority to go along with that responsibility.
And go ahead.
One thing that I will offer is that for the accreditation,
Yeah.
The microphone's off on.
It may be off.
Okay. I will offer this, that per the accreditation requirements, we do have a competency statement that the program coordinator, which would be myself, and the medical director, or medical directors in our case, has to sign off that these students have met all the objectives of the program before they do go out to that comprehensive internship. Maybe sharing that with the service medical director would be very beneficial.
Right.
That would be number 2.
The
That
issue
would be number
really-
2 on our policy statement, our position
EMS
statement.
students do not have a training permit, they're not licensed like physicians. I mean, they're truly not recognized by Department of State Health Services. So ultimately, they are practicing under not only the medical director, but probably more importantly, the preceptor, and that's probably even grayer, but that's the realities of the way the rules are written.
Yes, sir.
Hello. Very good. My name is Jerry Dinsmore. I'm CEO of PERCOM, Kilgore College Consortium. This issue was brought to our attention when the agendas for these meetings came out. We attend all the education committee meetings. This is the first we heard of this. We do have some concerns on moving this forward. One, the insurance issue. I am not entirely certain, and I haven't had a chance to check because this is short notice, if our liability blanket school policy will cover the student if the student is now underneath the direct control of a medical director that's not a member of our staff. It's something that does need to be looked into. Otherwise, I could be sending a student to your service, and now my policy doesn't cover him, and if he does something, God forbid, wrong, your policy doesn't cover him either because he's not an employee. I think it's something that needs to be looked at.
That requires you clarifying with your insurance coverage that it does cover them working under my service. Otherwise, you're not invited to come and ride on my ambulance. So you need that coverage. If you can't get it, your students don't get to come.
And I agree with that, but if the possibility doesn't exist for this coverage to happen, by passing your proposal here, you're going to shut down every student and every program everywhere. I'm saying that we need to investigate at some point whether this is a possibility and can move forward. The other issues, if this goes forward, every program out there is going to have to go rewrite every agreement that they've got in order to accommodate this. There are medical directors such as you that will work with the program, and you want this. There are other medical directors out there that see liability and run for the hills, and they don't want to assume this kind of liability. It's going to cut down on the number of services out there as potentials for students to ride out on.
That's right.
There's no assumption of liability involved. We are liable for all care delivered in our ambulances by whoever's hands. And so we're obligated to fulfill that role of authority over everyone who's in the back of one of our ambulances. That's all this is saying. We're not trying to delete or obviate the clinical liability on the part of the educational medical director. But when you're engaged in a clinical practice and a field service, that service medical director must be the primary authority as far as the care delivered in the ambulance. When a student is riding on an ambulance, they're not operating under protocols from the college. They're not operating independently to deliver care and assess patients and document on authority from the educational program. They're operating within that clinical system and have to follow that clinical system's rules. We're just clarifying that the authority within the system lies with the system medical director, not with the educational medical director.
Right. We're trying to make sure that the educational medical director doesn't get caught into this and that there's not a conflict between the two.
And let me just clarify, because I don't want us to get too far off track here. This position statement is not asking anything different other than clarifying the relationships that are already there. So it is not saying, hey, the system medical director wants to go out and assume new liability. You want some more liability? Anybody want some?
I would say we already have the liability.
We have it now. Let me be real clear, everybody hears me. We have it now. We're not asking for new liability. We're not asking that liability change, because it's kind of funny. We couldn't get that even if we wanted to. The liability is there. It is ours. They are practicing under our license now. This doesn't change that at all. At all. All we're saying is we need to recognize it and make it clear.
I understand that you are actually asking for a change by getting the medical director to sign the clinical affiliation agreements. And in my experience, attempting to get signed agreements, the more hoops you put for people to jump through, the harder it's going to be to get an agreement. That's why hospitals are so difficult to get, and EMS services generally are not, because most people that run the EMS services are paramedics that went through the programs, and they're very workable. They want to see students they went through as a student. When you start having medical directors, and a lot of the EMS services out there do not have active medical directors. They have a doctor that signed a piece of paper and says that they're a medical director. Those doctors, when they see this, I'm telling you, will refuse to sign.
Fair enough. You're right.
Well,
we are asking for another signature. You're correct about that.
Well, Jerry, I would say that if you're sending your students to a service that doesn't have an active medical director in the practice of medicine, you probably should be sending your students somewhere else.
I understand your point.
I mean, this is the practice of medicine.
Right.
It is.
we do try we have multiple contracts. We do try to send them to the best that we can. Unfortunately, sometimes you can't. It's just the nature of the beast. Thank you.
Thanks, Jerry.
Thank you.
My name's Don Reuter, and I am with Multiple Services, and I will tell you that I have checked with the malpractice insurance companies, and it does not cover the surface medical director if they are listed as the person that is responsible for that person while they are on the ambulance. It covers the program medical director. I've also had that, I've sent it to 3 different attorneys that looked at it. All 3 of them are of the same opinion. It will, our liability insurance, malpractice as it is listed now, will not cover an EMS service medical director who is covering our students because you're not part of the program.
Absolutely.
Okay.
I don't think that's a shock to anybody. We know that that's the reason, so I'm going to change hats again.
Okay.
I'm going to wear my EMS education program medical director hat and say absolutely, and I'm sort of glad about that because I have no authority over the paramedic preceptors. Now, I have some responsibility to make sure that they meet requirements, but I can't control their clinical practice. So I don't want I'm not trying to assume liability for them as an education program. Now, switching hats again, I'm the system medical director. I don't expect the education program's liability insurance to cover what I do as a system medical director. That's the reason I have my own malpractice insurance. So that's crystal clear. I agree absolutely with everything you said, but I think that's an understood thing.
Okay. Then the other question I have is if we're moving in this direction in EMS, what's going to happen to the hospitals? Because there are no medical directors in hospitals.
It's not a delegated.
So there,
It's not a delegated practice in the hospital per
okay,
se.
so there our medical director is responsible. The other thing, and I haven't talked to Dr. Hatch about this one, but during COAMP's visit that we had, we were told that you had to have the student signed off in competency in the classroom, in the lab, in the hospital, and in EMS. So this is going to require the medical directors now who are in these services to sign a statement that says this person is competent as an entry-level practitioner to move them to the next step to where we can get them out of the program.
Negative.
I disagree with that.
Well, that's something that's going to have to be clarified by COAMPS because they told us that they have to be signed off on a statement that says they're entry-level competent.
Correct.
core
I think you need to
competencies.
clarify, and we'll be happy to clarify it. But that is unfortunately, Deb Kaysen is going to be here
I'll
today or
clarify it on the
tomorrow.
COA board.
Yeah, that's an education. It's a question of whose hat you're wearing. And the problem is so many of us have the same 2 different hats. That is a responsibility of the medical director of the education program, not a responsibility of the medical director of the system. So as a system medical director, I am not responsible for assuring that those students have minimal competencies. That is the responsibility of the program medical director and the program director. As a system medical director, my responsibility is for the care that's provided, regardless of who is providing it. If it's in my system, because EMS is the delegated practice, if that care is going on under my license, I'm on the hook for it. And this statement doesn't do anything to change that. I mean, if there were a way to change it, that'd be great. I'd love that, but it ain't going to happen. I'm on the hook for it.
Again, that needs to be clarified because we were told that when they finish that portion, somebody's got to sign that says
Absolutely.
that they're done.
What I want you to understand is I'm not disagreeing with you.
Right.
I agree. I absolutely agree that that is correct. But the question is who? And that is a responsibility for the program medical director and the program director of the education program, not of the EMS system.
You should have processes in place already for that, as far as your preceptors signing off their evaluations and their supervisors signing off
we
those
absolutely-
evaluations.
we absolutely
And that
do.
process leads to the educational medical director. Shouldn't have to involve the system medical director.
We absolutely have those in place, but at this point, those students are continuously under the auspice of one medical director. That's the program medical director. Now, now.
There is no change. When those students right now, today, and yesterday and last year are operating on an ambulance in an EMS system, they are also under the authority of the system medical director. System medical director does not suspend his authority and liability and leadership over the care delivered in his ambulances for those students. They're not independent practitioners within the service.
And I've got one other question. They're going to be under your auspice. We know what we train them for in our program. They get into your service and you may have a skill set in one of your protocols that they haven't been taught in that education program. Under the direction of one of your paramedics, they perform that skill.
That's why they should arrive with a skill set list, and that paramedic would work only with the skills that they've been trained to. That's exactly what I was saying. You don't need to be training them on something they haven't been checked off on yet.
Right.
So the paramedic on the ambulance needs to know that at the beginning of the shift. What have you been checked off on? IVs, intubation, what? And then allow the student to work on those areas, not, chest decompression if they've not covered that.
Yeah,
The thing that I would like to, first off, I think this is a fascinating discussion because I didn't think there was really many questions about this, and I was obviously wrong. There are quite a few questions about it, but it's not a new concept. I am, system hat on, I am responsible for the care in that system. This is not a confusing issue. This is crystal clear. I don't care whether there is whoever does it. If Dr. Greenberg comes on one of my ambulances and does something silly, I'm on the hook for it. Now, granted, he is too, but it's not like I'm absolved of liability. It is my liability. Without a doubt, this doesn't change that. It doesn't create a new liability. All it's doing is saying, crystal clear, I'm the one on the hook. And I'm actually glad now because I think that there was some confusion, which I didn't really realize was there. I'm glad my colleagues recognized it, but we're on the hook for it.
Yeah, I guess the example I think of is you have a student that misses an intubation, the patient dies. The service medical director is responsible for that death. The program medical director is probably going to fail that student, but he shouldn't be the one that then has to go up and defend the care that was provided in the back of the truck. That's the service medical director.
And the concern there is from my providers of malpractice insurance, that student is not covered by our malpractice under the auspice of that EMS service provider.
Yes, that's correct. That's the reason that your students have insurance. So my liability protection protects me, not the students. That's why students have their own insurance. That's why the program has its insurance.
That's what I'm trying to tell you, is our providers have said that insurance does not apply if they're under the auspice of another medical director who is not part of the program.
That needs to be clear.
I think y'all just agreed by disagreeing. This clarifies that it's the service medical director's butt on the line.
And that
Very
students-
straightforward.
And that students with no insurance.
And what-
That insurance responsibility will go back to the provider.
But the student doesn't have a responsibility. They don't have a license to practice. They're practicing under the provider. I mean, they're...
But there is proximal cause.
But I guarantee
They caused
you,
it.
then ask your lawyers who you're asking the scenario to, the same situation as a men's intubation. They're going to tell you that they're practicing under the license of the medical director of the system.
That is correct, but there is still the assumption of liability because they were the proximal cause of the injury to the patient.
Well,
The student was.
let's take a look. Let's have a hypothetical example of Dr. Greenberg's student who, you notice it's not my student. It's Dr. Greenberg's student who intubates the goose and the patient dies for whatever reason. I'm on the hook because I allow my paramedics to intubate and allowed this student to intubate, let's say in the absence of waveform capnography, which hopefully would have prevented this. I'm absolutely on the hook. They're coming after me. Now, you are the plaintiff's attorney. Your objective is to get money because you have some mortgage payments coming up. So you're going to sue Dr. Beeson, who doesn't even know about this service. You're going to sue as many people as you possibly can. So of course you're coming after me and you're coming after him. But I'm the one that has crystal clear liability. that what is going on in my system is under my license. So I think
I
it
would-
is in
I would agree with
everybody's
that.
interest to get lawyered up before they put students into a clinical situation.
I would agree with that, but we're right back to the deal of it needs to be looked into, because at this point, the way you're talking about it, and the way I'm talking about it, that student has no protection.
If your students have no protection, then you've got a fundamental problem with your insurance coverage. Because what we're speaking of is not new.
The
Again, this is
insurance-
not a new change at all. That within an EMS system, the medical director is the authority over all care.
This is where the misunderstanding and stuff has always come in. The malpractice insurance covers the student in the EMS program under the auspice of the EMS program's medical director. If that student is under the auspice of another medical director, the policy that that program covers will not cover.
Then by definition, your insurance is saying they cannot have any clinical experience.
Yeah, based upon your policy
You just
today,
defined that their training cannot include getting on my ambulance, because I cannot allow any other protocol other than mine.
That's where the issue comes in with this,
Right.
because of the way the EMS programs have been set up and have run for years. It has always been the understanding that that program medical director was responsible for them even while they were on the units with DSHA statutes to say that the service was protected.
Yeah.
That's why this has become such an issue all of a sudden, is because our insurance at this point is going to have to be revisited and figured out what we're going to do.
Perfect.
It certainly
Exactly.
will, you know,
Right.
and I got to say, that's not
what
the
me-
understanding of the EMS medical directors. But, Mr. Chair, I'll call the question.
Okay, yeah. Thank you for your input. I think it's a great discussion. The question has been called, and actually, we have hit all three of the bullet points in the discussion. They are projected up on the board. I hope all the members of the committee have them. I read number one, and I'm going to, was it your intention to call the question on all three?
Have you read through all the rest of them?
I'm about to.
We thought you were doing it one at a time.
Okay, so we're going to call number one.
Actually, I move we accept number one as written.
There's move for acceptance, is second.
second.
Any further discussion?
I call the question.
Anyone opposed? That's right, you called the question. He called the question, I'm sorry. Robert's Rules of Order, okay. All right, anyone opposed? I'll take that as acceptance. Number two, the affiliation agreement between an EMS system and a training program should reflect the authority of the EMS medical director for all care provided. That's what we have discussed extensively.
The only thing that I think that it's important to reflect is the medical director is understanding or maybe even approval, because I challenge that most systems, medical directors don't have any understanding of how many students are rotating or how many affiliations.
That's number three, sir.
That's three?
That's number three, sir. I'm
I'm
sorry.
dyslexic, forgive me.
That was the Beeson
Yeah,
number. I did that for you.
I withdraw what I just said.
okay. Motion to approve, maybe? Somebody? Anyone?
I move we approve number 2.
Second.
Further discussion? Anyone opposed? Okay, that number two has been passed. Number three, DSHS should add a requirement to program approval regulations that requires the EMS system medical director's approval on any affiliation agreements between EMS systems and training programs. And I will say parenthetically, that's actually what we're here for, is to direct DSHS. So this is probably the most important one. Any further discussion on this item? Do I have a motion?
Motion to approve.
Second.
Motion and a second? Further discussion? No? Anyone opposed?
Does Dishes Legal have any input? Do we have any legal thoughts regarding this?
I think that's a good question. What does Dishes Legal think about it? This has not been to them yet, and I think it would be, again, we're talking about a circle. The function of this committee is to send it to GTAC. GTAC now needs to look at it, send it to Dishes, and have that discussion about legal.
Okay.
I hope Maxie is agreeing with me. Is that correct? Okay. I'm trying to get the work out of the committee to the council and to Dishes, which, quite frankly, I think is where it belongs. Anyone opposed to number 3? Consider it passed. I will take this position statement forward to GTAC on Monday night for further discussion. So if anyone who wants to discuss it, that will be the next discussion point at GTAC. It is a agenda item, so I'll discuss it at my report, but it's agenda item.
Do we need to also refer this to the Education Committee meeting tomorrow, I think?
It is on the Education Committee agenda? Okay. I was going to say referral to Education Committee would be the role of GTAC if it's not already there.
Oh, okay.
Okay, so that went so well that we're going to back up and go to number 7. This is from Dr. Bradley, who could not be here. He is deployed in, I think, Hurricane Sandy cleanup. Discuss and possibly forward to GTAC a position statement on EMS transportation to freestanding emergency departments, urgent care centers, and other alternate care sites. If you could you switch to that document? It's the other PDF that's in there, and scroll to the bottom. Dr. Bradley did an excellent job of giving some references, and then the recommendations at the very bottom is what we should consider. Does everyone have? Can you read it, Dr. Beeson? Does everybody have a copy? Looks like everyone does.
Do you want me to email this to you?
Yeah. I will let everyone read through it, and then I will ask for discussion. Can members of the audience see it and read it? No? No? That'll make the discussion better. Oh, I'm sorry. Is there a way to enlarge that any at all? Y'all want me to read it?
Not the whole thing.
Yeah, I'm not going to read that. I would only read the recommendation if I read anything. But
I would add one thing, that on number 3, there is some benefit to the overall healthcare system. One additional benefit may be that in the event all the major hospital ERs are on divert, which happens occasionally, that the freestanding ER may well serve as a pop-off valve, essentially, for some of those patients.
yeah, my intention, Dr. Moore, is actually to only take the recommendation, the bullet points from the last, and the recommendation from this document to be published officially as for GTAC.
Okay.
Otherwise, it's a resource document, not really a position statement. Dr. Beeson, you're unusually quiet, sir.
It's coming.
He can't quite get his word.
This is a tender subject. This is a tender subject.
Certainly, well, that's why we need discussion here. Again, notice the agenda item says possibly refer to GTAC. So if we need to do this some more and bring it to the next committee meeting, we will do that. So we need to hear everyone's view on this. Let me throw out the first statement and see if everybody is happy with it, or if everybody knows. The EMS Medical Directors Committee of GTAC's position is that current EMS statute and rules regarding EMS transportation to freestanding emergency care facilities are adequate. Good with that? Good with that? Everybody's quiet? EMS transport to these facilities may benefit the patient and the overall healthcare system and involve the risk of financial harm to hospitals unless there is strict avoidance of financial or insurance factors when EMS providers select a destination. Anybody jump in when you want to? Next item, the EMS medical director should, in consultation with local freestanding emergency care facilities, determine the capacity and capability to receive EMS patients. The EMS medical director should determine if each EMS provider should transport to local freestanding emergency care facilities. If the EMS medical director approves, policies for these transports should be written into EMS protocols and standing delegation orders. Y'all are being really quiet. Yeah. Each EMS provider that transports to freestanding emergency care centers should track the number of patients transported to these facilities and the numbers transported to hospital emergency departments. This information should be publicly available and include the payer mix for patients transported to each type of facility, with the exception of patients that must be transported to a hospital due to policies such as trauma or stroke.
So I think that this is one of these where the devil may be in the details. I think depending on the type of organization, my organization is a county department, so our information is publicly available. Whether, I mean, you can just do a Freedom of Information Act request if nothing else. The question is what are we talking about doing with this information? Are we talking about requiring it to be put up on a website or just given to people when they request it? It's the given to people when they request it is the current status quo. So we do that already. Honestly, I don't have a problem posting it to a website, but that's a technology we just haven't made use of yet. And then it's when we talk about that information should be available with the exception of, example, trauma and stroke. I'm not sure why that would be an exception. There's a good reason for it, but it's still where we're taking patients. Hopefully we would have a reason for why we took patients anywhere.
My recommendation for the last thing that I guess kind of bothers me is that if a provider transports to these facilities, it should track outcome data. I mean, that's covered in law. We already get outcome data. It's protected, and then everything after that should be just removed. Should track all outcome data patients transported to these facilities.
What, just to clarify, I know what kind of outcome data I'm most focused on with these facilities, but what is it particular you're talking about?
That could be defined by the EMS medical director. I obviously have outcome data that I want in my system, but I think to be specific in here with all these exemptions and other things, you know, publicly made available, that's just...
What is your I didn't, you said something about outcomes and I'm having trouble.
Yeah, EMS,
Where are you?
the last subset there, each EMS provider that transports to the freestanding emergency care center should track outcome data of patients transported to these facilities, period.
Oh, so you're recommending insertion of outcome data?
And then strike all the rest of it about hospital emergency departments, publicly available, exemptions.
So I'm not sure whether that creates chest pain for me or resolves chest pain for me. I'm still kind of on the fence. When we're talking about outcome data, the thing that I was most immediately thinking about, because I care about the outcome data of all of my patients, but when we're specifically talking about folks going to freestanding departments, the outcome data that I'm most interested in is how many then get transported back out. So how many of them are, where did we err? I mean, that's a triage decision. Did we take them to the wrong place? That outcome data is really easy because I have it. Well, I might have it. If you take them out, then I'm not going to have it. The outcome data that is a little more different is I take somebody in who I thought had a seizure and it turns out they had a stroke. What was the ultimate CPC score? I'm struggling to get that data right now in a lot of other places. And I'm all in favor of having a position statement, which we do, that says we should have access to that outcome data. I'm not sure that's what we're trying to do here.
I would say that the last paragraph is probably superfluous and could just be deleted. I mean, it says in the second paragraph, the EMS medical director should determine if each EMS provider should transport to local freestanding emergency care facilities. Well, that determination made by the individual medical director may include clinical outcomes, it may include transport outcomes. I mean, the local medical director can decide what criteria to use to decide, do we use or do we not use?
Okay, I agree with that.
And so I would submit we could just delete the third paragraph.
So that's a motion to delete the third paragraph under recommendations?
Second.
Discussion? Okay. That's a PDF file, so we can't do it up on the board. So we're back to sending forward the recommendation of the first two paragraphs.
I make a motion to send the first two paragraphs.
I'll second.
Further discussion? Come on up.
Hands.
We can always count on Doug.
Please identify yourself and your service.
My name is Dudley Wade. I'm from a small little EMS service between here and San Antonio. And these probably do reflect the opinion of my employer, but I'm probably supposed not to say that. I like what you're trying to do here. I notice there's a couple of things missing. Oh, I'm sorry. I like what you're trying to do here, but I notice there's a couple of things missing that are involved in other things, such as where we take stroke patients and how stroke patient facilities are identified, trauma centers and things like that. I think the medical director should in some way endorse, if at all possible, that this is done on a regional basis, so that it makes that identification of appropriate facilities easier if it's not a single medical director in a single system, where maybe that organization is high-powered and connected in the community, and there is other pressures on that medical director or that EMS agency, for that matter, to take patients where maybe they potentially don't need to go. So that's done from a regional, if there's a regional process for developing which of these are appropriate or not appropriate, especially in systems where there's more than one or two ambulance providers, I think that becomes a much more comfortable process for everybody. And the reason I'm speaking to this is because we're going through this in the San Antonio region right now, and we've pushed it to the rack. We're working really hard for individual EMS agencies not to have to get marketed, baited, enticed, potentially illegally into moving patients into these facilities. We're saying we've got all our EMS agencies hopefully pushing that to the rack discussion. And we're saying this type of facility is appropriate for EMS, this type of facility isn't. The other thing this does to protect the big hospitals, the motherships out there, is that it prevents those facilities from telling individual EMS agencies, hey, you know what, we can take anything but trauma, STEMI, and stroke. You bring us anything. Oh yeah, and psych patients. Don't bring us psych patients. Take those psych patients to the ER. Don't bring them to us. Or this other unappetizing group of patients that we're going to have a hard time getting a bed for. Don't bring those to us. Take those to the big hospital. And so if that's done on a regional basis with the hospitals involved in that, it protects the risk that you state in there. The other thing I would recommend, I don't mind the third paragraph from an EMS operator's perspective. I do not like the second line, and I think that's what you're tripped up on. I don't see a problem with you encouraging referral medical directors and the EMS agencies to track the number of patients that they take there. I think that's highly appropriate. The other piece, though, that I don't like in the statement is the second sentence of the first paragraph. EMS transport to these facilities may benefit the patient and the overall healthcare system, but involve the risk of financial harm to hospitals unless there's a strict avoidance of financial or insurance factors when EMS selects a destination. Every day, without these in your community, if you have more than one or two hospitals, you're probably using that information to select a destination. If you have a patient that wants to go to hospital A because that's where their insurance goes, and that's where all their records are, you're allowing that to come into play. That's a pretty powerful and maybe even potentially dangerous statement to get into having into this. Otherwise, they'll push it towards the RACs, or at least have something in there about the RACs' involvement in this, if that's appropriate in that local community. And then I would take out anything that has to do with payment.
So what, and I think I get your 2 points, one of which is that the second statement in that first block, EMS transport, that's more of an editorial comment, and you think that doesn't belong in there.
Yeah.
Okay. And then the second one, I think I get it, and I want to make sure that I'm understanding you. You're saying that we should recommend that the medical director makes these decisions mindful of the regional guidelines, if there are any guidelines.
Yes.
Okay. I think that's very reasonable, and I would say basically for the second paragraph, that we basically say should, in consultation with local freestanding emergency care facilities and mindful of regional transport guidelines, determine the capacity capability.
I think it's up to the medical director.
Well,
I think the medical director has the ultimate responsibility for destinations.
Well,
And if I don't agree with what the region agrees, it's my license.
Absolutely, and that's the reason I said mindful of. It doesn't mean you have to adopt them. Just think about them.
Okay, so actually, Dr. Jarvis made a motion to add mindful of or some sort in there. Is there, first of all, there has to be a second on that before we discuss it. And if there's no second, then we will not.
I would second that.
Okay, so Dr. Moore seconded it. You've already discussed it.
I mean, it does leave some flexibility.
And as
Okay.
further discussion, I'm not wedded to that wording.
Right.
You know, with consideration given to regional transport guidelines, that means we can consider it. It doesn't mean we're obligated
Talk
to
to the
change
microphone.
our decision. I'm sorry, with consideration for the regional transport guidelines, referring back to the RAC and the regional destinations. And that means we consider it, but we don't necessarily have to make a particular decision. We're making ultimately the decision for the right destination for the patient anyway. That's what we do every day.
But does that put pressure on me because I'm not doing what my region recommends I do?
Well, you always do what's right for the patient, right, Dr. Beeson? I mean, we know that.
I would like to think so, but sometimes I'm delusional, so.
All right. I'm not, yeah. Any more discussion on adding the verbiage? If we don't add the verbiage, it is as stands. And certainly it would be up to whoever. To the microphone, please.
I'm Daryl Pyle. I'm the CEO of SETRAC, and I'm a hospital administrator by training. I see that you have this listed as a possibility of recommending it.
Correct.
If this could be delayed until your next meeting and allow the RAC or any interested RAC in their EMS medical director committee to review Dr. Bradley's wording, that would be wise. We're actively looking at this in Houston, which is probably home to more of these freestanding centers than any other city. It is a Pandora's box, and there's pros and cons to this. There's wording here that concerns me a lot when you're talking about the financial status. Right. I'm not sure that should be part of what you're want to project in this kind of a statement. So if there's any chance to push it back for the RACs to give you input before your next meeting, that seems wise.
Yeah, I will, at the point we're at now with this policy statement, the number of changes we have made, I'm not going to forward it to GTAC. I'll discuss it at GTAC, but I'm going to bring it back to this committee at our next meeting in February. That is the time period during which the RACs can look at it, it's posted to the website, and they can comment on it. Whether or not we're going to specifically reach out to the RACs and say, what do you think, is a totally different story, and not, then I'm editorializing here, not the way the system should work. If the RACs want the committees and GTAC to work, they need to pay attention to what we're doing. Everybody gets the meeting notices, everything's posted on the website about a month ahead of time. So, and that's where the information is supposed to come here. Dr. Bradley is from Houston, and the members of the committees are picked, you know, for geographic reason. So with the number of changes we're making today, I think this significantly changes the statement, and I think that it needs to come back to this committee again before it goes to GTAC, because it does need to go out for further review. So I think we're agreeing on what you're asking.
Thank you.
I have to agree with Dr. Beeson, though. I don't necessarily feel bound by the RAC to determine my individual practice. And wording that paints it that way could be potentially difficult in some practice settings. And I think I'd also want to volunteer that I know the wording about the financial concerns is a little uncomfortable for some, but considering the state of medicine these days and the fragility of our emergency room systems, I think it's important to be aware of the impact of these freestanding centers. Now, as you decide whether you're going to use them or not, I think it's important to be mindful of that, and that's all we're saying here.
Right. I'm sort of trying to do the rule-y thing about Robert's rules or whatever. Right now, we're just talking about adding the language, if that's okay. Yes, sir.
Yes, good morning. My name is Angel Romero. I'm the Vice Chair of CBRAC, and also Director of Emergency Services for multiple emergency departments in Corpus Christi through HCA Gulf Coast Division. I just want to make sure that the committee can review The first paragraph, freestanding emergency medical center facilities must be licensed by the Texas Department of State and Health Services.
That is true.
That is not correct.
Yes, that is correct.
It is actually, it's
If you are,
tied to the
I'm sorry to
facilities.
interrupt you. If you're a freestanding emergency department, you must be licensed under the state. That does not apply to urgent care centers and other freestanding facilities that hold themselves out to provide care. But if you are a freestanding emergency department, you must be licensed under the state. And I'm looking to make sure I'm saying that right.
Well, I know that if that's the case, I know that we have been put on hold specifically because we couldn't get our facilities licensed so that we could actually apply for trauma designation. So if that's something that's changed, then I think that we'll try to pursue that on the level 4 trauma facility and tie those into our freestanding emergency departments. So I appreciate that information and clarification. The other question that I have is, or just really a comment back to the last statement, and it looks like it's going to be reviewed, is the requesting that EMS providers provide the data on the numbers of transports of the facilities that are going. Be mindful of the rural EMS providers that do not have the resources of larger facilities or larger programs to be able to provide that information. We do get a lot of business from rurals to our freestanding emergency departments, and of course I'd want you to consider them as well.
Yeah, we've actually already struck that portion.
Thank you.
The third paragraph has been struck.
Question I have for you for clarification. Are your facilities licensed under a hospital, or are they truly freestanding? Are they standalone or freestanding?
They are standalone freestanding emergency departments that are tied to a facility. We have one that's a freestanding emergency department that was licensed previously that is now a freestanding because it was consolidated. We have since built another freestanding emergency department that is tied to our current license facility. It does not have a license itself. We were directed that it did not have to have a license. It's been open for a year and a half.
That's a different thing.
Yeah, that's a
Standalone and
different
freestanding are different entities.
And that's part of the problem is all of these are not created equally.
That's correct. And
that's
just,
why.
just for clarification of that first statement, I think would be
Okay.
great. Thank you.
Are you saying that they would have to be under the same like Medicare numbers as the big hospitals?
Yeah.
So that's why I'm asking for that clarification. It needs to be there. Thank you. For
Okay,
your
thank you.
consideration.
We're actually still going back to mindful of regional. We have a.
So I'm just typing it out, and like I said, I'm not particularly wedded to any particular verbiage, but what I've said is, second paragraph, the EMS medical director should, in consultation with local freestanding emergency care facilities and in consideration of any regional guidelines, comma.
He doesn't like it.
Well, then strike it.
Yeah, actually, I mean, this is easy, actually. We just take a vote and see if we want to add that language in or not. It will come back to the next meeting of this committee, so we can wordsmith, if that's okay. So I'll call I can't call, well, can somebody call the question?
I could, but I really could care less about this particular thing.
I'll call it.
Okay, question's been called. Who's in favor of the word change? Raise your hand or say me.
Me.
Two me's. Opposed?
Say no.
Okay, I didn't even have to vote. Okay, cool. So that will not be changed. The second paragraph will stay as it currently is. Is there another? There was another recommendation from the floor to strike the second sentence of the first paragraph about financial information.
I'll move we do that.
Okay. Move to strike the second sentence of the first paragraph. Is there a second? And there's
I would
what?
second it if we can supplement it with some other
Okay.
statement that would say that, in the spirit of the mindful, that we would be mindful of any financial impact to your overall system.
Yeah, you got to, sorry, you got to talk in the,
Yeah, I would just say maybe the wording is what we're disagreeing with, but any decision for destination for our ambulances should also be mindful of the overall impact on the health of the local EMS and healthcare system.
so we have a recommendation to strike and revise and bring back to the next meeting. Something that's more palatable? Is that what I'm hearing? I'm leading the audience.
Yeah, that would be fine,
I second that.
Cool.
It needs to be in there, we need to.
but in a different way.
But in a different way, okay.
I'm in support of anything where I get to type the word mindful.
Yes, I like that word.
So Dr. Jarvis has volunteered to redo that sentence.
Why not?
We will actually, if Dr. Jarvis, the committee that looked at these two was Dr. Jarvis, or the work group, I'm sorry, make sure I say this Open Meetings Act correctly, was Dr. Jarvis, Dr. Bradley, and myself looked at these. So I will ask the same three of us to try to fix that second sentence, which has now been struck.
Mr. Chairman, is there a way we can also address Angel's comments about making sure that the license requirement is clear? Do we need to add the words freestanding emergency care facilities operating under existing hospital emergency departments shall be licensed, or is that, how do we need to? We can do that, okay, good.
Okay. All right, so I'm not going to take over. So what's coming back to the next meeting will be the first paragraph, the first line of the first paragraph under recommendations with a new second line, the entire second paragraph as it is intact, and the deletion of the third paragraph. Are we all in agreement? We good?
Right.
Cool. Okay, so I will report on this to GTAC, but I will not submit it. I'll report on it, and it is an agenda item, so it's up to Vance Riley as to what extent it gets discussed. I can tell him how much we've worked on it. Thank you. All right. Moving on, I have not seen Dr. Kidd. Is she here? Dr. Morriber is here unless he ran screaming from the room.
No, he's here.
There he is. I'm sorry. Dr. Morriber, could you give us a report on guidelines for triage and allocation of resources during a pandemic?
Good morning. Can you hear me? Good.
Good.
We had a meeting yesterday. We brought up a number of points. As you remember, the last time we talked about ventilator registry. We talked about ventilator registry. We talked about the informed consent and a number of other issues. What we want to do now is develop a timeline, and as the Institute of Medicine has in their paper they recently put out on crisis standards, they have 3 different areas that they talk about: conventional standards, contingency standards, and crisis standards. Looking at the pandemic as the most likely event that may befall this country, we have to amalgamate or try to incorporate some of what they've said into what we are doing. As you know, there are 3 levels of transition for pandemic. One is the surge, which is level 1. The second one is level 2, which is at capacity. And the third one is, oh my God, what do I do now? And that's what we want to prevent. As you remember, any event has a bell-shaped curve, and I'm trying to paint a picture for you since I don't have a slide. In this bell-shaped curve, at the height of the bell-shaped curve is when most of the problems occur. What we want to do is to delay that height, push it over to the right, and possibly bring it down in time that we can have a vaccine available. So what we're discussing now is changes in what will occur prior to or just preceding level 1 when we see the maximum surge, and try to prevent the problems at capacity. So we're talking about communications, getting the word out. We do a good job now with standard influenza, but we are not doing much when we come to pandemic. So we need to talk about proprietary and public information. Proprietary basically between the services, and also filter this down to the local health departments. Public information, which deals with protection, prevention, protection, and procedures that the public can follow. and then whether we develop local jurisdictional agencies or bring it up to jurisdictional information centers. In doing this, we also need to develop what we call the informed consent, because it's fraught with legal and ethical questions anytime we start to put somebody on a ventilator, and then we have to remove them for failure to progress. So we need to have these in place also prior to the onset of level 1. We're also talking about force protection, because you know we have oxygen that comes to our hospitals, food, electricity, sewage. It's not just the hospitals, it's the whole community. So we have to make a decision on who would be the most likely candidates in our environment, in our communities, to receive antivirals and vaccines on an initial basis. So we have to look at this as far as force protection, then we have to look at force protection for our own healthcare workers, because we have to consider elder care, child care, pet care. Transportation is a big problem coming to and from work. There may be areas that transportation is not allowed. There may be areas that are quarantined or isolated. So we have to make sure that these are all opened up so that our healthcare workers can get through them. So what we're going to do in the next intervening time is develop programs, stretch out a timeline, look for specific trigger points, and then talk about all of these. What we want to do is develop a strategy and then bring it down to the local level and let them develop their own tactics.
Do you need anything from our committee, sir?
Our next meeting is the 18th of January, when we're going to discuss this, so anybody here on the committee is more than welcome to attend.
Okay. Anybody have any questions for Dr. Morber?
Where's the meeting? Where is the meeting?
It will be at the Dishes Smock.
All right. Thank you very much, and thank you for all the work you do on this. You're a real workhorse. Is there anyone here from the Air Medical Ground EMS Task Force Work Group, whatever we are calling it? We do have an agenda item for an update. Is that what you're going to do? Excellent.
Justin Boyd, EMS Committee. I spoke to Mrs. Corbell earlier this week, and she was detained. Is that better? Yeah. Okay. She's been busy at her real job, and she's been working on the draft questions that we're going to present to, I think, legal and to the state on where we're at. We've met a couple times, not since our last meeting that we had in August, I do believe, but she's still vigilantly working on the questions that will be presented to the state for interpretation, and we'll move forward from there. She hoped to have it out to the committees this meeting, and I did not hear back from her, and I haven't seen her, so I would ask that we continue this process, and we'll have an update at the next meeting.
Okay. So the survey is still being done? Okay.
Yes.
Should we have you back at the next committee for another update?
Yes.
Okay. Any questions? Thank you, sir. All right. Next is agenda item number 6, update on Texas Medical Board Rule 197.3. I do not have a copy of it with me, but it is published in the Texas Register for comment. I'm not sure how long that comment period is. The rule, which we've talked about before, and we cannot send from this committee or from GTAC because it's not within our scope, deserves some comment. Quite frankly, there's a "or" missing, in my opinion, between a couple of the items. I would ask all the members of the committee to please look at it. And if you want a copy of it, please send me an email. I can send it to you. I think we do need to comment on that. Items number 9 and 10, I'm sorry, just 9, says discuss and consider making recommendations on the EMS education rule. I missed this when I reviewed the agenda. I'm going to turn to the state and ask, is that actively being reviewed? Is that why this is on here? I'm confused.
We are reviewing the rules. I'm not sure why they put that particular item on it, but we are still working.
Okay. That missed my...
What is 157.32?
Well, I wish I knew. I'm not sure what 157.32 is. Can the state... I'm sorry, I missed this when I looked at the agenda. I did not see that item, and I have not reviewed it.
It has to do with educational course approval. I don't know what specifically.
It has to do with educational course approval.
I'm sure it probably goes in
Okay. I'm sorry. I'm at a loss, and I apologize for that. Anybody, any of the educators in the audience know? Help me. Nobody? Okay. Since we're ignorant of the fact, we will not discuss it. Not that that always stops us. Okay. Yeah, you heard me. Number 10, this is carried over from previous. This is something Dr. Phillips, who just entered the room, sent forward. I think we had some discussion about this, and there was some confusion about something that COA-AMSP had done about, I think this says intubations. I believe it was actually more appropriately airway management. Dr. Beeson, I think you're probably the most knowledgeable on this. Could you give us a down and dirty?
So there was a campaign of disinformation that went across the country about this statement. And there was fear from educational programs that COA was putting out a requirement for 50 intubations. And so it went out that just that nobody was going to be able to meet that. This was a multi-year process that included subspecialties from anesthesia, pediatric, emergency medicine, pretty much everybody on the COA board. And this position statement deals with the difficulties that programs are having getting live intubations. And so the actual statement, I'm sorry I don't have it here, but it talks about pretty much, like you said, airway management experiences. It discusses simulation. It actually mentions in high fidelity simulation, I believe is the wording, which a lot of people are having we can't afford high fidelity. I don't know what high fidelity is, but and there were some other concerns for one point I know that's been a hot topic that it mentions as far as conformation of endotracheal tubes. It mentions fogging of the tube, which, you know, bent a little people wrong because that's not a conformation thing. So I know the board, we meet again in February, and some of those things will be taken into consideration, but the position is solely a recommendation to programs, and it deals with the minimum requirements of airway management and not a number of intubations.
I think part of the confusion that's come about is that it's a minimum requirement, but it's a recommendation. And so part of it is, and I agree, the paper needs to be cleaned up is part of the issue, because there are some, I guess you'd say errors is a nice way to put it. One concern that I've got is, and what I've heard from a couple of educators is, this really doesn't say that we have to do live intubations in our paramedic class, and I have some heartburn with that. I think there needs to be some live intubations that are considered minimum, but as you know, that it's difficult to get those intubations in the OR and especially in a teaching facility such as where you're at. I hear myself.
Talk close.
So I know that's one of the issues. As far as the high fidelity simulations, I think that they're thinking more like the SimMans and some of the Medis and some of the other simulators that are able to do a lot more. And you know, I encourage the use of those personally. I think that that's a wonderful tool, and I know that there's several facilities, companies, agencies in our areas that are willing to come out and help students and educators with that. So I think that really more than anything, you know, the language needs to be cleaned up, in my opinion, so that it's more of a recommendation rather than a minimum requirement.
Well, from the COA standpoint, the COA in its standards does not set numbers for anything. The COA views the standard as you take recommendations from your community advisory board on what your program needs. And so, you know, we deal with this quite a bit on what's the number. You know, people will put 1. Is 1 enough? No. Well, then they put 2. Is 2 enough? Well, once again, so the position of the paper was simply a recommendation, and it's probably the first that I'll tell you the intent was we were trying to get people away from actually an intubation, a number of intubations, and realized that intubation is not the problem. It's managing the airway and deciding if the patient needs to be intubated or not. And so I wasn't part of the writing of this, but I do applaud the COA for attempting to get away from the actual procedure of sticking a tube in a hole and realizing there's so much more to that.
Any other discussion or anything that we need to do about this? I think from the time this got put on the agenda till now, there's been a lot of clarification. You okay with that? Okay. Before we go to general public comments, are there agenda items for our next committee meeting? I already have down that we will discuss again the transport to freestanding facilities after it's been revised. Dr. Jarvis has already sent me a draft. If you could be quicker next time, I'd appreciate it. We will hear from the Air Ground Task Force. We'll hear from Dr. Kidd and Dr. Moriber. And I'm going to try to find out on item number 9 about the education rule, so we do not miss anything. Are there other agenda items?
I'm sure there will be. We can add them
Of course
later.
there will be. Yes.
Okay.
I think it's of note that the pediatric committee is studying the use of CTs and.
What did you say? We can't hear you.
Hello. The pediatric committee has a statement being created for use of CAT scans in kids, and it's not particularly an EMS medical director saying, but all ER doctors need to know what's going on.
That item will go to GTAC, the council in whole. It's not on our agenda, but I have some concerns about whether or not it's appropriate for GTAC. It's a great piece of work, but I'm not sure it's appropriate for GTAC, and we'll be discussing that. Pediatric committee is not meeting over the next 2 days. They canceled their meeting.
Okay. Maybe trauma will look at it, because a lot of it's CAT scans and trauma in kids.
Right. I will open now for public comment, if there is any further public comment. And to everyone's surprise, Dudley is coming to the microphone.
Hey, Dudley.
We actually do appreciate you, Dudley.
Hey, two things. One, when you get these up and they're going to be on the agenda, make sure you get these up so I can make sure I've got the right people from IRAC here for the next meeting, because I think that's important that we get them here. The other piece is you guys are looking at a lot of really great things, and you're doing some good work, and I appreciate that. One of the things that I stumbled across in my system recently that kind of shocked me a little bit is that you can't have an initial education program without a medical director involvement. You guys are pushing, and I support, that the medical directors need to acknowledge the students riding on the ambulances and all that, but anybody can go out and get the permission to teach state-accepted CE without a single medical director's signature, acknowledgement, or anything on that. And I think that's a shortfall. I know we skipped completely over that and didn't realize it when we were looking at Chapter 157, but it came up in my system because I had a small first responder agency go out and get their CE certificate. And so our medical director and them had to have a little bit of a discussion about exactly what it was they were going to be teaching outside of his approved CE. So, but it was kind of shocking, and we went and looked, and there is no medical director involvement in the CE process at all. So maybe something y'all want to take a look at.
Do you for clarification, do you think it has to be, are you saying it should be an EMS medical director involved or just physician involvement? Or, because I hate to bring it up, that could come under your college's medical director.
It could, but
So-
so the college has to have a medical director to teach the EMT and paramedic.
Right.
But that's for you guys to haggle out, honestly, and maybe we get education involved, and I'm going to bring it to them as well, because I think they've not seen that either. The only reason it's a little issue for us is just because of how easily it happened. It's just, the process doesn't even go to the local office anymore. I don't think. I think it goes to the state, and so it was just processed up here in Austin. Nobody knew about our system, and they got that CE number. And my medical director was quite shocked that they had the capacity to award their own folks CE outside of his purview. So,
I think it's a good point, but it goes beyond the state. CESBEAMS does not require it, and so, it's, yeah.
I'm going to walk back in my chair. Do you know why? I mean,
No, I actually
why you
have
need
never-
it for initial but not for continuing? That seems just odd.
I'm in awe that you brought that forth because that's a great thing. I'm just, wow. Wow. From Dudley.
Hey.
My name is Eddie Walker, and I'm the EMS Program Director for Life EMS Academy in El Paso, Texas. One thing about the recommendation from COAMS about the intubation stuff is that for programs like mine that is now going through the accreditation process, we kind of take those recommendations as the gospel because it seems like sooner or later those recommendations become requirements. And it poses a problem, not with just my program in the city of El Paso, but with the one other paramedic program that is going on now. My understanding about this recommendation is that it says that intubations can be done on the low, medium, high fidelity. However, the majority of intubations should be done on live patients. I don't remember if it says should or may be done on live patients, but above that, it also says that on the last 10 patients, the student should show a competency of at least 90%. So they're going through the OR for their last 10 patients. They missed intubation number 5 and number 6. Their 10 still have to start over on their 10. That extends clinical times for them. That pushes and can delay other students being able to get into the ORs, which are a very difficult place to get to start with. Okay? But I'm taking those recommendations as kind of requirements, and right now I'm following those recommendations for my students in my paramedic program. It is going to present a bit of a challenge whenever they start going through the ORs. Just wanted to let you know that. Okay? Another thing about the medical directors and education programs. 100% agree, absolutely, that medical directors are ultimately responsible for all care in their system, whether it's done by their personnel, students, nurses, or a homeless person that a crew picks up off the street to do care. And if there is something that is done that goes against the protocol of that particular service, then there's a failure of intelligence on both the student's part to do that, for which they have not been trained, and 2, on the preceptor for allowing that student to do that. Concerns that I see with this is not having the medical directors approve the affiliation agreements or taking the responsibility, which you already have for something. It is that if the insurance for that program nullifies because of the involvement of the medical director system on that affiliation agreement, we need to find a fix to that.
Right.
Okay, because that's a real big problem for the program. One mishap, and regardless of the liability clause that we have in 773, it could still cause a real problem for the program. Okay. Another problem that I see with it is the possibility that some services will say, well, these students coming from these programs need to prove to our people that they are competent in those skills. And in order to be able to do that, we're going to have to pay our personnel to check these students off on the skill. Therefore, we are going to pass that cost on to that student or that program, which can cause an increase in that program that is already high enough as it is. Now, for those that are college programs, that may not be much of a concern. The student goes another semester, they just add another lab fee, they add it on to their student financial aid, and they pay it on the back end. But for those programs that don't qualify for that type of financial aid yet, such as my program, then there's another additional cost that occurs to those students that they're going to have to pay up front for that program. That can cause some real concerns in some of the areas like El Paso. We've gone down from 4 paramedic programs to 2 paramedics within the last 3 months.
And I'm sorry to cut. Were you here when we discussed all of this during the discussion of that rule?
Yes, and I didn't get a chance to discuss it because the question had been called.
Okay.
So these are just things that you may not have thought of that are concerns for some of the programs.
That needs to go to. You need to make sure you're at the council meeting.
I will
for
be.
those to be aired. That would be the place for that.
Okay.
Not trying to cut you off, I'm really not, but
It seems
I can't go back to redo that, what we've already, the motion we've already
I'm
done.
just letting you know of some things in case you hadn't thought of those. Just
Right.
bringing it to your attention is all that I'm doing.
Well, I understand, but again, I'm trying to follow the process to make us more efficient. That item is going to the council, and we're done with it. So the council is where you need to bring up those concerns. I don't want to bring it back to this committee and then delay it another 3 months.
I would also point out that since the emphasis in the COA paper is on airway management, just because you miss an intubation doesn't mean that you're unsuccessful in managing the airway. And I think that hopefully is going to be taken to the board as well.
And Eddie, I would recommend you take that paper to your community advisory council committee, and if they don't agree with what the recommendation is, remember, the standards come from KHEP. All right, COA is interpreting the standards and the recommendations, so it's not a requirement. That's not what COA is about numbers, like I said earlier. It's based upon what your community advisory committee thinks your program needs.
And out of pure irony, the last thing I wanted some input from this committee on is there's, the council is going to consider limiting the number of days that GTAC meets, GTAC and committees meet, and possibly limiting the amount of time committees have, including this committee could go down to an hour. We are 1 minute away from an hour and a half, but I would like to know what people think about that. If you come to me individually, or if there's something you really want to say about it now, we can do that, or come to me individually, not as a group, so we don't violate Open Meetings Act. But the council will be voting on that on Monday evening as to whether or not we're going to try to shrink down GTAC and committees. We are at our time. Is there any further business? Move to adjourn. Thank you very much. You get full attendance, Dr. Phillips, even though you got here late.
When's the next meeting?
Our next meeting will be probably February the 28th. The next GTAC is February 27th, 28th, and March 1st for the council.